metastasis is seen in left axillary node, then what is the name for that? This I'll tell you. First I'll enumerate and then I'll tell you. Then if it is in left supraclavicular node, if there is a cutaneous deposit around the umbilicus, then what is the name for that? If there is a palpable intraperitoneal metastasis on digital rectal examination, and if there is involvement of bilateral ovary, both ovaries. Okay. Okay, so if there is metastasis to the left axillary nodes in a patient with CA stomach, it is known as Irish nodes. Irish nodes. Okay. If there is presence of left supraclavicular node, then it is known as Virchow's node. Virchow's node, and this sign is known as Troisier sign. Troisier sign. Okay. And if there is a cutaneous deposit around umbilicus, then it is known as Sister Mary Joseph nodule. Okay. This is not a lymph node. This is a Sister Mary Joseph nodule or nodule we can say. This Sister Mary Joseph was a nursing staff, and she identified this cutaneous deposit around the umbilicus in the patients who are having metastatic deposit, and based on her name, this was named as Sister Mary Joseph nodule. Okay. Now, this palpable intraperitoneal metastasis on digital rectal examination is known as Bloomer's shelf. Okay, Bloomer's shelf. And this involvement of both ovaries is known as Krukenberg tumor. Okay, and most common route for developing Krukenberg tumor is retrograde lymphatic. Retrograde lymphatic. Okay, so all these are metastasis, and if we have a clinical suspicion or we have palpated these sites and there is some nodule, then we'll go for palliative chemotherapy in these patients. Okay. Now, what is this finding? There is a patient who is having anorexia, weight loss on upper GI endoscopy or on barium swallow. We have identified this kind of finding. So this is leather bottle stomach. There is shape like leather bottle, and this leather bottle stomach is seen in linitis plastica. And in this linitis plastica, there is diffuse proliferation of fibrous tissue in the wall of the stomach. So the wall of the stomach becomes very thick here, and there is diffuse proliferation fibrous tissue in the submucosa. Okay, this is linitis plastica, and the most common symptom is early satiety. Early satiety. Okay, the most common symptom is early satiety. Barium swallow finding is leather bottle stomach, and the treatment of choice is surgery. What surgery? Total gastrectomy. Okay. Okay. Now, the next topic is what is the TNM classification for the CA stomach. It is the 8th AJCC TNM classification. There is T1A, T1B, T2, T3, T4A, T4B. In CA esophagus, I have told you T4A is involvement of resectable structures, T4B is involvement of unresectable structures. Okay, so now we will be studying about 8th AJCC of carcinoma stomach. This T1A is involvement of mucosa. Okay, which include both lamina propria and muscularis mucosa. Now this T1B is involvement of submucosa. This T2 is involvement of muscle or muscularis propria. T3 is penetration of, this T3 is very important here, penetration of subserosal connective tissue. Without involvement, this line is very important, without involvement of visceral peritoneum or adjacent structure. Okay. In CA esophagus, the T4A was involvement of adjacent structures, but they were resectable. But in this CA stomach, this T4A is involvement of visceral peritoneum. Visceral peritoneum or serosa. And the involvement of adjacent structure is T4B. Okay. So if a CA stomach is involving pancreas, it is T4B. Okay, simple. Now this is N1, N2, N3A and N3B. Involvement of 1 to 2 lymph nodes, 3 to 6 lymph nodes, 7 to 15 lymph nodes, or 16 or more lymph nodes. Okay. The minimum number of lymph nodes which should be removed in a gastrectomy specimen is minimum number of lymph nodes removed at least 15. In some books it is written as 16, but at least 15 should be removed in a gastrectomy specimen. Okay. Now, gastrectomy for CA stomach. Okay. So the gastrectomy for CA stomach is mainly a subtotal gastrectomy or a total gastrectomy, is mainly a subtotal or a total gastrectomy based on the location. This is mainly, and along with that we do a lymph node dissection. Okay. So this lymph node dissection is divided into D1, D2 or D3 type of lymph node dissection for gross understanding, because it is very complicated to remember these lymph node stations. If the lymph node stations is present around perigastric region, okay, 1 to 6 is perigastric, removal of them is D1, 7 to 12 is along named vessels, okay, which includes left gastric or splenic, hilum, hepatoduodenal ligament, common hepatic artery along the named vessels, then it is D2. This includes D2 includes both D1 and this station 2. Okay, and so this is D2 is 1 to 12. Okay, this is approximate to understand. This is not the exact version. Okay, and if the retroperitoneal lymph nodes, retroperitoneal, like para-aortic, in between the IVC and aorta, superior mesenteric artery, these lymph nodes are removed, then it will be known as D3. Okay, retroperitoneal lymph nodes, then it will be known as D3. Okay, which includes all D1 plus D2 plus D3. Okay, so this D3 is associated with complications like diarrhea or chyle leak. That is why the most preferred is D2. Okay, most preferred is D2 lymphadenectomy. So whatever gastrectomy we are doing, along with that D2 lymphadenectomy is the correct or the current recommendation. Okay. And how much margin we'll have to take? We'll have to take a 5 centimeter margin. So we'll do a subtotal or total gastrectomy with a 5 centimeter margin, and along with that we will do a D2 lymphadenectomy, which will include all the perigastric lymph nodes, and along with that it will remove the lymph node along the left gastric artery, the splenic artery or the hepatic artery, which are supplying the stomach. Okay. Now, based on the location, what kind of surgery we'll have to perform? Okay. Suppose if a tumor is present in the antrum or pylorus, or the most common tumor, okay, then there is a second tumor which is present in the body, and then there is a third tumor which is present in the fundus region. Okay, so for this antrum tumor, we will do a subtotal gastrectomy. This subtotal gastrectomy is with a D2 lymphadenectomy. This D2 is with all these locations. This body tumor, we will do a total gastrectomy, and in this fundal tumor we will do a total gastrectomy with a distal esophagectomy. Similarly, in with this G junction tumors also, we will do a total gastrectomy with a distal esophagectomy. In G junction also, the preferred is total gastrectomy with distal esophagectomy. Okay, this is the preferred. There are other methods also, but this is the preferred method for treatment for G junction tumor. Okay, so now for diffuse variety, the treatment of choice is total gastrectomy. Now, if there is involvement of pancreas, I'll tell you, if there is involvement of pancreas, if there is involvement of head of pancreas, generally the surgery is contraindicated, as adding a Whipple's along with a gastrectomy is associated with a lot of morbidity and mortality. And if it is involving the tail of pancreas or body of pancreas, generally a distal pancreatectomy is added. Okay, and in the cases, in which cases the spleen is removed, splenectomy. If there is direct involvement of spleen, or if there is tumor, okay, this is spleen. So if there is tumor which is present here in the greater curvature, if there is tumor in the greater curvature along the posterior wall of stomach, at level of fundus, okay, in close approximation to the spleen, then we'll do a splenectomy along with the gastrectomy. Now, what all are the prognostic factors? In CA esophagus, the most important prognostic factor was T staging. Okay, here the most important overall prognostic factor is stage, overall stage, which include both T and N, and single most important is lymph node stage, lymph nodes which is more than T stage.